So again, my name is Katy. I'm one of the neuro-oncologists here. I am a neurologist, but I did do some stuff in the back. And I'm going to give you an overview of neuro-oncology, which is focused on glial tumors primarily. I'm going to run over some stuff really quickly, just to try to focus on glial tumors, and what I think is going to be relevant for your guys' work. Because some of you have already rotated me in clinic, and I'm happy to have any of you and all of you come to our clinic. Okay. So we're going to talk about the difference between primary and secondary brain tumors. We're going to talk about the symptoms, and then I'm going to, since I'm a neurologist, I'm going to push about how important location is, localization in the brain. We're also going to talk about how we diagnose brain tumors, particularly from an imaging perspective. We're also going to do some math. Then I'm going to quickly have 3 slides on secondary brain tumors. I'm going to let John Kirkpatrick give you the best and most awesome brain that lecture, which I'm sure he'll be able to give to you. And then we're going to focus on primary brain tumors, and this is really a focus on astrocytic and glial tumors. Sound good? Okay. So, this is question number 1. This section is one of my patients. Okay, so patient A is going to have multiple lesions on MRI in here. Assuming this is a metastatic disease, what primary neoplasm is usually responsible for dissemination of multiple lymph? Is it Leopold carcinoma, prostate, melanoma, or blood cancer? Which usually causes multiple lesions? Melanoma. Yes, right. Leopold carcinoma tends to be solitary. The other thing you need to know is always that renal cell and melanoma are the ones that like to bleed. Okay. Next one. Patient BY has a glioblastoma, known by this nice lesion up here in the temporal lobe that also has a surface lesion in it. What molecular marker is a predictor of a better prognosis? Is it MPMP methylation or monomethylation, EGFR-B3 Q-monosomy, or 1p18q deletion? Yes, it's MPMP methylation promoter. We'll go over that in a second. EGFR-B3 is associated with a poor prognosis, which we'll also go over. 22q monosomy. Does anybody know what tumor that is? And we'll see if one of your exams. No, it's a pediatric tumor. Atypical teratoid rhabdoid tumor, ATRT. Yes, you're in there. I'm not going to teach you guys that today. We'll have a few other questions, and then one thing daughter of patient BY wants to understand the risk factors for the development of brain tumors. Which one of the following decisions increase risk of developing primary brain tumors? Seasonal allergies, usage of cell phones, vitamin D deficiency, or exposure to ionizing radiation? D, yes, exposure to ionizing radiation. Seasonal allergies are associated with that? Okay. So, regular phone usage, and finally, vitamin D deficiency is associated with the development of MS. Okay? So that's a little wrong here. So, brain tumor, again, is an abnormal mass in the brain portion. We can have other masses, right, like Abs disease or sarcoid disease. Primary brain tumors are going to originate actually somewhere from in the intracranial sphere, whether it's the brain itself, the supporting structures, organs and surrounding structures of the lumen. And secondary brain tumors are simply anything that's metastatic to the invasion into there. So the common differences between primary and secondary that you just need to know sort of fact. Primary brain tumors usually present early adult to midlife. In adults, they tend to occur above the tentorium, the tentorium cerebelli, so they occur above the tentorium, versus children, it tends to be infratentorial, so more below the tentorium cerebelli. For metastatic tumors, this can be anything, right? Anything can metastasize to the brain. But our favorites are lung, renal cell, melanoma, and breast cancer. Okay? Also the GI tract tumors. They are usually supratentorial, so above the tentorium. And they tend to occur at the gray white junction. I'm going to show you guys some good examples of that. Okay? So what are the symptoms of a brain tumor? Okay? How do these patients usually present. And so how will you see them, usually with metastatic disease in your clinic, how will your patients present? Okay? So the symptoms can be, they're very common for the neurologic review systems. Patients can have headaches, they can have fevers, they can have focal neurologic symptoms, such as hemiparesis, and they can have more global metastatic abnormalities. What's really interesting is when you start breaking down the tumor types, there's actually some symptoms that seem to sort of fit with others more, with other types of tumors more than others. So metastatic abnormalities are commonly seen in things like primary CNS lymphoma, where it's more of a global process. Low-grade gliomas become very infiltrated tumors, actually sit in the brain and don't cause more focal symptoms per se, actually assisting with the development of seizures. Okay? So there's something to know about low-grade gliomas. And then seizures for malignant gliomas or meningiomas are sort of a whole gamut of symptoms that can occur. So what is the headache like for a brain tumor headache? It tends to be occur about a third of our patients, and it can occur within the disease trajectory about 40 to 70% of the time. It tends to be very intermittent and non-specific. Some patients will say it's right there underneath, right where the tumor is, but it can vary from the side to side. It doesn't have to have size to it. But the most common symptoms that are associated with it is that it's a headache that occurs upon awakening and improves throughout the day. Okay? And the headache is exacerbated by any kind of postural change. This is associated with increased intravenous pressure. For seizures, okay, again, this occurs about 30% of our patients have primary brain tumors. And really the location of the tumor will predict whether the patient's going to have seizures. If it's in the temporal lobe, okay, it's going to be more likely to have seizures. If it's sort of deeper, okay, in the basal area, you may expect more focal symptoms rather than having a seizure itself. Okay? And this is just a breakdown of different symptoms, okay, of pre-developed seizures. And what you can see here is that the low-grade tumors, we'll go over grades in a second, so don't worry, are more likely to be associated with having seizures in the astrocytoma and meningioma, whereas glioblastoma is less likely to be associated with actual brain seizures. More with focal symptoms, headaches, and even metastatic abnormalities. We also can see increased cranial pressure. This is an example of papilloma. This is going to be more common in children because the tumors tend to be more slowly growing, so their brains can accommodate it. But also the fact that a lot of remember, tumors in childhood affect the intracorporeal, so they're going to actually block the ventricular system. So that can lead to hydrocephalus and in turn increase their cranial pressure. You can also see cranial nerve 6 palsies. Remember that cranial nerve 6 is your lateral rectus, innervated lateral rectus. So that's something that you can also see. And patients will also have vomiting, sometimes projectile vomiting in the pediatric population. This is just an example of one of our patients with a glioblastoma who actually had herniation associated with brain tumor. You can see actually the large enhancing mass here on his coronal section. And it's pushing down. You can actually see the ventricle here is obliterated. And he had pretty serious herniation and uncle herniation here at the temporal area. So herniation occurs, hopefully you get a neurosurgical evaluation. In the meantime, you want to decide to do steroids, 10 to 20 milligrams IV Q4 to Q6, mannitol and hypersaline, and of course intubation and hyperventilation. Induced successful craniotomy can be performed and also neurosurgical catheter. So what's really interesting is this guy actually drove down when he was down in New York and showed us in our ER with one people. So yes, it does happen. And lo and behold, because he had such a large herniation, basically he ended up bursting via the posterior cerebral artery into the tensorial herniation. And also, this is a great example. He has little flame-like hemorrhages right here in his brainstem. These are called gray hemorrhages caused by the shearing of the funcking vessels. So, this is just a nice picture of high-quality real estate. I think this is actually for that. Right? So this is all about location, location, location. So your diagnosis in brain tumors is all about where it is in the brain, okay, whether it's frontal, parietal, temporal, occipital, whether it's in the posterior process, and what kind of symptoms they'll have. So who feels really comfortable with their neuroanatomy? This is not a neuroanatomy course. I will tell you, I've taught neuroanatomy to other groups. You need to know the basics. I'm happy to do neuro exams with you guys if you want to go and learn some fun things, finish the neuro with my children. It's more efficient. But you got to remember this rough diagram. This is the frontal lobe. It's all the way to the central sulcus. Behind that is the post-central gyrus. This is the parietal lobe. It goes to the parietal occipital sulcus. Behind that is the occipital lobe. And below this, the lateral fissure is the temporal lobe. And we have sitting in here is our brainstem, and then also our cerebellum is in the back. Okay? So for frontal lobe, you're involved with motor cortex, movement of the facial limbs, executive functioning, memory, production of speech, and emotional control and personality. If you imagine you have a lesion there, it's going to affect all these things. So let me just show you the things that you do. Okay? For example, for the temporal lobe on the left side, it's involved in cognition of speech. Hearing can also be involved. Memory lives in the temporal lobe at the level of the hippocampus. And the right temporal lobe really doesn't know much at this point. It's the cognition of So this is an example of the dysfunction that can be there. I'm quickly going over this because this is not a neural lecture. Okay? Parietal lobe, again, is the sensory cortex. This is where patients may actually have difficulty with detecting sensation. They may have a syndrome called neglect syndrome, where they don't recognize one side of the body or one side of the world. Left-right recognition is important in the parietal lobe, also calculation and spatial recognition. And this is just an example of that neglect that we see. This is what should look like normally when the patient's asked to copy a clock, a house, or a flower. This is to the mid part of that. Suggesting that patient should have a neglect syndrome. And then finally, the occipital lobe. These are easy ones. This involves visual processing. This is when you actually detect the field effect. And then for the brainstem, cerebellum is responsible for balance and coordination. The brainstem is involved in eye movement, cranial nerve function, swallowing, and also it controls all the long tract signs. And what the long tract signs are is everything that involves either the spinal tract, okay, or all the sensory tracts coming in and out. So you can actually get motor and sensory symptoms along with eye findings and cranial nerve dysfunction from a lesion in the brainstem. That was just neuroanatomy 101 with that. Sorry about that. Let's get to the meat of how to diagnose brain tumor. So imaging is really important for us. So imaging not only helps us with the initial diagnosis, but it's also going to help us when we're following our patients. So CTs are done sort of in an emergency perspective, and CT with contrast will help you visualize some tumors. But again, in the posterior fossa, it isn't very good, okay, to look at those kinds of tumors in the posterior fossa. And if you have tumors that don't enhance the contrast, you may actually miss those tumors. So really, an MRI is really our preferred modality. So if you come to our clinic, you'll see that we do MRIs anywhere from every 2 months to maybe every 6 months. Sometimes patients that we're following on a yearly basis to once a year. We can see non-enhancing tumors and enhancing tumors equally well on those images. But still, there's probably some good therapies that will change the way the tumor looks. Some of the differentiation that makes things look worse than it actually is. Sometimes you have to use things like PET or SPECT, or even have to go to biopsy to really understand whether it's a tumor or treatment effect. So PET scans are being used to really assess for tumor grade. And so low-grade tumor, it won't really light up on PET scan, but if it's higher-grade tumor, you're going to expect to see sort of a lighting up associated with a higher-grade tumor. It also can be used to differentiate between radiation damage and tumor. But sometimes those things are not always consistent. So a lot of times you have to push patients to get a biopsy. Because even though these things can be used to differentiate between those two things, they aren't 100%. And so this is just an example of a CT. So again, the bone is bright on CT, and you have your nice cortical ribbon. You can see all this horrible dark and in here, and here's the target bone lesion, enhanced lesion. This is an MRI, and this is one of my patients. I came to the patient that has metastatic melanoma. This is a T1 with contrast image. We know that the T1 because the white matter, okay, is lighter than the gray matter, which is the cortical ribbon. And these are all the mets. And you can see, remember, they are sitting in that gray-white junction. we feel like an MRI expert, right? This is an example of imaging that we use for glial tumors. So this is an example of a glioblastoma in the temporal lobe. So FLAIR imaging, which is just a T2 imaging when the CSF waves out, you will see that the gray matter, okay, which is the cortical ribbon, will be lighter than the white matter. But if there's edema, which we'll see sort of fluffy around this region, it will appear in white. Okay, so it's practice for edema. And this is the example of the lesion itself. You see one with contrast. Okay, this is an example of a different type of tumor. This is a meningioma. Has a much different characteristic. You can actually see it's coming really from the outside covering of the brain and sort of pushing in. Not associated with as much edema, but a little bit around the ventricle. Okay? And it has a very homogeneous appearance. It's not that product. It's all different. This is my favorite picture, because this has a GBM here on the frontal lobe. This is actually the patient's meningioma. So I actually use this to really compare what the difference between those two tumors look like. Okay? You're like, it's your favorite picture. It's very sad. This is a great explanation. But again, you can see the ring-enhancing mass of the necrotic center, if you're with me about that, and then the homogeneous area here. You got it? You're going to know your meningioma and GBM. Okay? And then finally, for PET scans, it just shows that this is an enhancing mass and that there's increased activity here. Okay? That's the most important imaging. Whereas on low-grade tumors on MRI, you won't see as much activity. Okay. So how else do we diagnose it? We have to have pathology, just like with you guys. Pathology is the gold standard. I hate to call from for this, but we're going to lesion. We want me to see that it's hereditary, like I said, right? It could be toxin, it could be sarcoma, it could be anything. So we have to have a biopsy. We also need cerebral spinal fluid, and I think you guys can do a lot more CAPs than we do for primary brain tumors. It's very important in the pediatric population because for germ cell tumors, you can actually look for those same kind of markers that you look for particular cancer, or for other germ cell tumors that can occur when the inheritance or but you can also look for involvement of the whole axis, particularly with CNET tumors, for adenomas, tumors that tend to like to disseminate through the CSF. So I'm going to quickly do just secondary tumors. So most common intracranial neoplasm in adults, okay, that's a secondary tumor. I would suggest that if you really want to have somebody really talk to you about brain mets, go to Patrick, Alvin Cabrera, which is a really great talk. Have some really interesting information. So it affects about 10 to 30% of all patients with cancer. And the frequency of diagnosis seems to be increasing over time. Some factors have been, you guys are going to treat your patients. Okay. We have better ways to look at their brain. So if anybody has a neurologic symptom, aren't you getting an SCT, or you're getting an MRI, or you're even considering it and thinking about it? And then the aging population. There is also some suggestions that some of our targeted agents don't go across the blood-brain barrier as well. So they're very good at controlling maybe systemic cancer, but not as good as going across the blood-brain barrier. This tends to be a site where you actually, your skin through the site where cancer can go to hide. So you need to know the most commonly involved ones. You need to remember the categories. So lung, particularly small cell lung cancer, is associated with brain mets that tends to predominate in men, even though women are getting more and more lung cancer. Breast cancer, and this is something you can see also for meningeal disease. Melanoma, colon, and kidney. Now, melanoma has the highest tendency to produce multiple lesions and to have more dissemination to the brain. Renal cell cancer tends to be a very solitary lesion. And interestingly enough, even though I told you that brain mets like the supratentorium, renal cell cancer likes the posterior fossa sometimes. So it's something that you see a bloody lesion in the posterior fossa in renal cells. And about 10% is IPH, and that can be melanoma, renal cell carcinoma. The other one I'd like to ask you is choriocarcinoma. Okay? These are the right entirely. Okay? These are all fairly important questions. And when we do the surgery can be done for sort of an isolated lesion versus a few lesions. We use a lot of radiation, whether it's pre or post-surgical. Sometimes it's going to be given whole brain radiation prophylactically, but what we're using more is actually stereotactic radiation surgery. So John Kirkpatrick and John Clinton do a lot of that. And then chemotherapy can be used for, if you know, the primary underlying neoplasm. So that's all I'm going to talk about with metastatic. Okay? So let's get to the primary. Okay? So this is a rare cancer. Cancers actually are very rare, about 1.4% of all newly diagnosed cancers. And only about 2.4% of the cancer-related deaths. Gliomas are really the most common. So they're about 49% of all primary brain tumors, with 80% of the gliomas actually being a WHO grade 3 or WHO grade 4. And if you even had to push that even more, the WHO grade 4, which is glioblastoma, is really the most common tumor. And the average age of onset is 54 years, so this is an adult population. Even though they're common in the pediatric population too, this is the average age for any kind of brain tumor. So how we define these are the histological appearance and also you need to understand the pathology of brain tumors, and I'll try to give you guys a crash course today. So really, what kind of tumor you develop really depends on the age. And I like to show this in really comparing a pilocytic astrocytoma, which is a WHO grade 1 glial tumor, tends to occur, you can see what I'm trying in here, tends to occur more in the pediatric population, but is very rare in our elderly population. Whereas a glioblastoma, which is the most common type of glial tumor, is very rare, okay, in the pediatric population, but then it peaks in the elderly population. It depends on how old you are, what kind of tumor you have. So the World Health Organization essentially classifies tumors based on their cellular origin and their histological appearance. And the most important, you have to stage stuff all the time, right? Staging is important. I will tell you, I never stage anything unless it's a neuroblastoma or maybe a ependymoma. It's very rare, and usually I have to figure out how to stage it. Because I just don't do that. Grade is our bread and butter, and grade is so important. If you're thinking of anything in the brain tumor world, you want to think of grade first, okay? Staging is really left, okay, to those rare tumors that spread through the neural axis. So I like to show this slide not so that you just have to learn all of this histology and pathology all at once. But I like to think of it as this is a normal astrocytic population, and these are astrocytes gone bad, okay? And it makes them very easy to see this in the pathology. These are some nice stellate cells sitting through the brain parenchyma, and these are crowded cells with definite pleomorphism, with evidence of necrosis, and they seem to be palisading on top of each other. Okay? So this is an example of GBM, and there's no blood vessel here. Same thing here. These are normal oligodendrocytes. This is an example of the oligodendroglioma. Okay, we'll go over the pathology in a minute. But the same thing occurs for other types of tumor types. So this is a normal ependymal cell from flooding the central canal. And this would be an example of an ependymoma. These are the meninges, and this is an example of a meningioma. So you can sort of see the basic difference in the cells from that, and lots of them. And then also, you can actually keep these slides. You have to get these slides, right? When I give them, you get these. Okay? You can just keep these as your example. So again, this is an example of the normal granular layer, okay, in the cerebellum. And this is what it looks like when people develop a retinoblastoma, or pinoblastoma, or retinoblastoma, any of the primitive neuroaxonal tumors. And then finally, there's myopathy leading to the neurofibromas or schwannomas. So one of the risk factors associated with brain tumors, and this is what patients and family members often talk to me about, exposure to ionizing and radiation seems to be the only proven factor. Other ones that have been evaluated have included occupational exposures, electromagnetic fields, pesticides, cyanothrones, chromosomes, but essentially nothing has been definitively proven. Interestingly enough, you can actually see brain tumors in populations where they had, particularly pediatric populations where they had cranial radiation. So this is actually a very important thing to try to limit radiation in the pediatric population. But children that had radiation for ALL have increased risk of developing brain tumors, particularly in the genome. Interestingly enough, we actually used to use radiation for leukemia capitans, if you can believe that, and those patients actually will develop angio and leukemia. Good cases of sort of knowing the radiation exposure and knowing what tumor they developed. I have a patient who had tonsillitis, actually radiated his tonsils. And right behind his tonsils, in his brain parenchyma, he actually has an angioma sort of infiltrated up into his cavernous sinus, which is horrible. Then I have a lovely, lovely woman, and she had a birthmark right here. And her mother had radiated into his child. And right under that birthmark, she has several lesions in glioblastoma. And interestingly enough, her husband died of glioblastoma, her first husband, and she's only glioblastoma. Those are two that I know that are definitively. We have some other patients that are like, long-term survivors of ALL who have multiple lymphoma. Those can be very difficult to treat. So think about what you do to a patient, what's going to happen down the line. We are having more survivors. So what about familial risk factors? You're going to need to know for your boards about NF1, NF2. You're going to need to know about things like tuberous sclerosis. Those are very, very rare cases. So that represents about less than 5% of familial cases. And it's going to occur mostly in the pediatric population. The other tumors that I want you to remember is lymphomas, okay? Because you can actually see that connection with sarcoma, breast cancer, and also brain tumors associated with that. Kit Gerson at Hopkins said that tumors can actually occur in families where there's really no predisposing hereditary disease, but it seems there may be some clusters and may be associated more with environmental factors. And that's what we need to understand. I have a patient right now. Her husband is 40 and has some weird lymphoma. She's 35, has glioblastoma. Another family member has another, and they don't seem to have anything genetically going on, but you just wonder, is there something in their environment that seems to cluster? There's a high frequency of incidence in their siblings, and they were validated in cases. And you need to know all of the genetic mutations, okay? These are really good parenting questions for boards, because one of them might answer, okay? And there's a really nice compendium of all the tumor genetics in the paper I have in my office. I also give a neurogenetic lecture because of the one. I'm very opinion further. Okay? I can just do that on the spot. So let's focus in on glial tumors and subtypes. And these are also what we call gliomas. A lot of times you hear like us talk about cystic gliomas. This is where we're lumping all these tumors together. And the reason we want to go over these is because they're the most common. So an astrocytic line essentially comes from an aberrant astrocyte, or we'll talk about the origin of brain tumors in a second. We have an astrocytoma, anaplastic astrocytoma, which is a grade 3 designation, a glioblastoma. Pilocytic astrocytoma, this is a grade 1 tumor. This is in the pediatric population. Pleomorphic dendroastrocytoma, this is actually a grade 2 type tumor, which is in the temporal lobes due to epilepsy. And then subacute giant cell astrocytoma. Here's what disease that's associated with. This is a common tumor in tuberous sclerosis. Okay? What to talk about. Oligodendroglial tumors are oligodendroglioma, and also anaplastic oligodendroglioma. And you even have a subtype known as oligoastrocytoma or anaplastic oligoastrocytoma. So these are just the different pathologies seen with the different aspects of tumors, and they go from grade 1 to 2 to 3 to 4. Okay, and the grade is really determined on how it looks like underneath the microscope. What is it? How many mitosis it has? Does it have intravascular proliferation? It also does it have necrosis. When you develop microvascular proliferation and necrosis, that's when you're going into the grade 4 category. So you're going to need to know that because that's something that they're always going to ask you. What sort of differentiates sort of what's upstream and what's downstream? Okay? And it's going to be that microvascular proliferation and necrosis. and also to help us determine prognosis and treatment for our patients. So this is a diffuse low-grade tumor, that's in grade 2. It tends to occur in young adulthood. They can be associated with seizures, also can have phone symptoms, headaches. On T1 imaging, it tends to be very hypointense. On T2, it's very hyperintense. It has very diffuse boundaries, so you can see some of the boundaries here. So it can look a little fluffy and diffuse, right, on imaging. The test is usually hypometabolic. But when we look at the pathology tends to be sort of a lot of monotonous cells sitting together, okay? They have some different pleomorphisms, but you don't really see any mitoses, and you can actually see what is called these little microcysts in the tumor, actually the tumor tissue. But then there's a rare subtype, this big arrow points to this big cell. These are big, foamy, fluffy cells that have a lot of eosinophilic cytoplasm and has sort of a nucleus that sort of goes to the rim. See how the nucleus sort of goes to the rim? These are called genistocytic cells, or genistocytes. This is usually associated with low-grade tumors that tend to have more of an aggressive type of a picture. The ones that are more likely to transform to a more aggressive type of tumor. The median survival is in about 5 years for these kind of tumors. It's usually you wish that has not happened in these tumor cases. You don't want these patients to transform to a higher grade tumor. And this is the higher grade tumor that they can transform to. So this is an anaplastic astrocytoma. This is grade 3. It occurs a little bit later on in life. And on MRI imaging, it doesn't have that central necrosis. You'll see sort of patchy enhancement. It's very patchy. Yeah. And now, when you go to the pathology, like, we still have that pleomorphic population, which will start to see mitoses that have in that era. But the one thing you won't see, you'll start seeing mitoses, you'll start seeing more cellular pleomorphism, but you won't see microvascular proliferation, okay, and you won't see necrosis. Because if you get those things, that's when you're going to glioblastoma. Okay. The 5-year survival is 15 to 20%, okay? But it can depend based on the pathology. The mixed grade 3 with all the astrocytoma, they actually may have a better prognosis. But again, the primary concern here is you don't want to transform to cancer. So finally, this is glioblastoma. This is more common in our elderly population. It tends to have sometimes a butterfly pattern, okay, on radiographic imaging. This is one of my patients with a large butterfly BVM. And you can see here, it has sort of these ring-enhancing areas with necrosis in the center, okay? So you can see the difference between the anaplastic astrocytoma. And on the imaging pathology, there's marked pleomorphism. These cells are very different, lots of crowded cells, and they can line up in this palisading pattern. Okay? And then sort of underneath that palisading pattern, very close you can see sort of an area of sort of necrosis. So again, that's one of those defining factors. And then you can also get vascular proliferation, so you can see the blood vessels. And that's what really makes that enhanced, right? It has that vascular proliferation. The 5-year survival is less than 5%. So very aggressive tumor. So what makes this a glioblastoma? Everybody told me they don't want it to transform. You can actually get a glioblastoma 2 ways. You can actually have a primary glioblastoma where it arises de novo, and that's what we usually see. Or you can have a secondary glioblastoma. This means it comes from an astrocytoma or an oligonucleoma, and it essentially has gene mutations, and it kind of turns into that bad glioblastoma. They seem to be genetically very different, okay? They also respond different to therapy. The secondary glioblastoma tend to be easier to treat, whereas the primary glioblastoma tend to be more aggressive. You have treat lung cancer patients, right? You guys know how important EGFR is for lung cancer treatment. In some ways, EGFR is very important in glioblastoma. It tends to be upregulated in glioblastoma, and you can also have a mutant variant known as EGFR-P3, which I'll discuss really quickly. That's very common in the primary glioblastoma, along with downregulation of P10. In the secondary glioblastoma, it has a much different pattern. It tends to upregulate central-derived growth factor receptor. It tends to downregulate and have mutations in p53. And there's also a separate mutation in secondary glioblastoma that, if it occurs, is associated with a good prognosis, and that's known as isocyclic dehydrogenase 1 and 2. And this is just another example of exactly what I just showed you, okay, the different pathways. So I want to mention epidermal growth factor receptors. I think this is important because it sort of brings in sort of the lung cancer world, okay, to the brain cancer world. So remember, it's a tyrosine kinase receptor. It has to dimerize in an asymmetric way, which leads to signaling and leads to growth of cells. This is seen before, right? Okay. Remember, it has an extracellular moiety and an intracellular moiety. Okay. And what I think is really interesting is that you're studying non-small cell lung cancer and begin to know where the different mutations are. Okay? So in glioblastoma, okay, they tend to have duplications, okay, at the kinase domain or deletions at the carboxyl cell. Whereas very different mutations that tend to have point mutations or small deletions in non-small cell lung cancer. But probably one of the most interesting things is you can actually have a deletion and point mutation at the ligand binding area, and this is called the EGFR V3 variant. And it actually makes the protein really constitutively active, and it doesn't really need to dimerize, okay, now, to cause growth. And this is just an example of that. This is a truncated or deleted variant, an EGFR V3 variant. And it occurs in about 10 to 30% of all glioblastomas, and it's associated with a much poor prognosis and a very aggressive subtype. But what's interesting is that there's a vaccine, okay, a small peptide vaccine called Celldex CDX110, and in the ACT-2 trial, which was performed here and also at other centers, the median overall survival in that trial was, if you added it on to standard of care therapy, was 24.6 months versus 15.2 months for historical control. So that's actually currently in a phase 3 study. So that's actually something you guys need to know. What's sort of the difference? I'm trying to bring some of the lung cancer world, the brain tumor world for you for a little bit, because I wanted to show you those differences. Okay? Any questions on that? That's cool. So back to some of the mutations here. Okay? So what I just want to mention also IDH mutations, and I think this could be a fair game question for your guys' board. So IDH is isocyclic dehydrogenase, and it's part of the Krebs cycle. Okay? And there's other mutations that can occur. This can be seen in colon cancer and thyroid leukemia. But a large majority of secondary GBMs have this mutation. And when they have this mutation, it's associated with a much better survival. I'm just going to show you the Kaplan-Meier curve. So this is just showing you that this mutation occurs more often in secondary GBMs or lower grade tumors. And look at these curves, okay? If you have IDH1 that's mutated versus IDH wild type, you have a much different survival. And there's some very interesting technology going in Dr. Hayon's lab where they're actually trying to develop compounds to target that mutant, okay? Because it does seem to be tumor specific. Okay, so I'm not going to go into the biology of it, but it's very interesting. Okay, now there's some more pilocytic tumors. Some more astrocytic tumors. The first is a pilocytic astrocytoma. This is a grade 1. So this is really a pediatric tumor, okay? Likes to occur in the posterior fossa. Usually it looks like a little mural nodule where it enhances with a cyst associated with it. Or if it occurs in neurofibromatosis type 1, okay, it actually will occur at the optic nerve, okay, so optic nerve glioma. But they have the same pathology. And the pathology is essentially a biphasic population of cells, and it has sort of these red clumps called Rosenthal fibers, which is essentially a big ball of glial-fibrillary acidic protein. Okay? This has a very good prognosis, and there's also a way to diagnose this to confirm whether it's a polycystic astrocytoma using the RAS fusion mutation analysis. These are very big questions. Pleomorphic xanthar astrocytoma, this is a much rarer tumor. Occurs usually in the temporal lobe. It has that same kind of mural nodule look. And it can have these folded lipidized cells. Okay? Now one thing to remember about this is it can do this in seizures. Okay. And then finally, ependymal giant cell astrocytoma. This occurs in the second decade, and you're really only going to see it in concert with tuberous sclerosis. And it likes to sit in the ventricle, particularly the lateral ventricle, or near the third ventricle, and it's these very large, enhancing tumors. So one way I can see you guys being asked about this is the drug everolimus, which is a mTOR inhibitor. It is actually used to treat this because TS leads to a mutation downstream to cause increased activity of mTOR. Oligodendroglial tumors. This is just an example of how to look at FLIR imaging and then also a T1 with enhancement. Tend to have very faint enhancement, very, very subtle, very different than an anaplastic astrocytoma. And it has like this flare signal that's around it. These can be both grade 2 and grade 3 tumors, and they can be very, very sensitive to chemotherapy. They tend to like the frontal lobe and the temporal lobe. They have two types, the well-differentiated and anaplastic oligodendroglioma, and deletions of one P19Q are associated with a better prognosis and a better response to chemotherapy. And when this is the pathology, this is the classic pathology, it's monotonous cells. It looks like this little fried egg, and in the background you see this fine vasculature, it's called chicken wire vasculature. Okay. And this is just an example of showing how the patients that have one P19Q deletion have a much better prognosis. Okay. So how do we treat these? So how do we treat the treatment in the next less 20 minutes, or less 10 minutes? Okay. Are we doing okay? Is this too much? Okay, so how do we treat these brain tumors? When I would tell patients, they come to see me in clinic, I say that it's the mass, and it has these fingers that like to come out from it. So we have to sort of locally control it and also do systemic control. So surgery is really our first step for local control, followed by radiation, and then the chemotherapy is really the systemic. And when I talk about treatment, I'm really talking about treatment for glioblastoma here, which is the more common subtype. So what does surgery do? It's going to relieve tumor burden. It's going to allow him to make a diagnosis. If the patient needs a shunt, you can put a shunt in. Okay. It also is going to want to introduce local anti-neoplastic agents. If we want to make a vaccine from the tumor, these are all indications for surgery. Now, radiation is really the next step. Okay. So for high-grade tumors such as an anaplastic astrocytoma or a GBM, we're going to utilize radiation. Numerous trials have shown that resection alone versus radiation, you're always going to have a better prognosis if you add radiation to that. And the total dose is about 6,000 centigrade. Okay? So even though I say that this is a total dose for anaplastic astrocytoma and glioblastoma, there's a lot of new information on the elderly. Okay? They can't tolerate radiation as much. So we now are doing actually protracted radiation schedules in the elderly patients. So instead of the 6 full weeks of 6,000 centigrade, we actually will do 3 weeks. Okay. And that's just something we're doing more and more. That's actually pretty new. Okay. So this is just sort of how chemotherapy got introduced to brain tumors, and we're sort of behind the 8 ball, okay, compared to other groups. The standard of care in the 60s was really surgery followed by radiation. You can see that this is the median overall survival. And then they have foray into nitrosureas, the CCMU and BCMU, and it really didn't improve the overall survival much. You can see that. So then they had a combination of PCV, which is procarbazine, and crispine, versus BCMU, and it did show that PCV actually improved overall survival in anaplastic astrocytomas, but not glioblastoma. So it was thought that PCV was really the chemotherapy for AA. And then, in 2005, the STUPE regimen, which is indigenous to limonite radiation, really changed things for the brain tumor community. And what it found is with radiation, the overall survival was 12.1 months, but with the addition to the hormone, 14.6 months. So this is statistically significant. This has been sort of the mainstay of the standard of care therapy. And we're sort of moving into the targeted immunotherapy age. So this is a paper by Shoup to sort of define how to treat primary brain tumors now, particularly glioblastoma. And what the trial looked like, it compared radiation alone versus radiation temozolomide, followed by adjuvant temozolomide course for about 6 months. The temozolomide dose is at 75 milligrams per meter squared, followed by 150 to 200 milligrams per meter squared of temozolomide for 5 days, and then you were off for 25 days. And this is just an example of the two Kaplan-Meier curves, so you can see the difference between the two curves. Okay? And the overall survival is different. I think one of the most important statistics here was the 2-year survival with radiation alone was 10%, with radiation temozolomide at 10%. So really good survival with radiation temozolomide. This is really what standard of care looks like. Okay? So we have a surgical resection, we wait about 4 weeks, we begin radiation temozolomide. We want the brain tissue, we want that skull to heal. And then we do 6 weeks of radiation therapy. We then wait about anywhere from 2 to 4 weeks because the MRI can look very different right after radiation. Okay, it can actually look much more enhancing. And then we do the MRI, then we do actually the dose-dense temozolomide for about 12 months. That's different than the 6 months that was in the STEW trial. Most centers in the United States actually will try to extend and possible out to 12 months. Now, temozolomide is a very important drug. It's going to just do your pharmacology, and I'm sure you know. You guys use temozolomide in melanoma? You should, right? There's Dr. Uranus uses it for something. So, in this way, instead of one, there's different regimens, okay? And the common regimen that we must see is going to be 75 milligrams per meter squared for 6 weeks during radiation, or really the dose-dense regimen, which is 5 days on and 23 days off in 28 days off. Side effects are constipation, nausea, vomiting, increased liver function, hypersensitivity. You basically have bad skin reactions, have bad rashes. They can be thrombocytopenic, leukopenic, and anemic, and can also develop fevers and myalgias. And this is just an example of the hematologic toxicity seen with temozolomide. So what you need to remember is that this protein, MGMT, which is methylguanine methyltransferase, is associated, if it's in high levels, it can actually repair that temozolomide damage that we want to happen to the cells, and we want to have low levels because of that. And not only that, you want to have the promoter of that gene methylated itself to sort of turn off that gene, and that's associated with a better prognosis in glioblastoma. And this is actually Monica Katy, who is actually the wife of Roger Stu. Found this, she's actually a PhD, and did this analysis of MGMT gene silencing that benefited temozolomide. So this is just where the little tick marks right here is where it would be methylated, or usually where they would polymorphism. So this would be the area that could all be, this is actually the MCM60 gene, and this is the promoter that would be hypermethylated. And this is just the difference between the two groups. You can actually see the methylated MGMT promoter group has a much better survival than the unmethylated group. Okay? So this seems to be very important. So the next step is, do you want to even give temozolomide to those unmethylated patients? Right? Is it going to be useful? Okay? And if they have a high MGMT, is it going to be useful? Well, there's also a little study in here. Because what you do see, okay, is that this yellow line is the methylated with radiotherapy plus temozolomide. This green line, or sort of the light blue line, Carolina blue line, is methylated with radiotherapy, whereas the unmethylated with radiotherapy plus temozolomide is the blue line. So even though they're unmethylated, they did better than just radiation alone. So right now, for Duke, we are not using MGMT to define whether you receive, okay, temozolomide or not. Most patients will receive temozolomide. So it's not something that's predictive of changing your therapy. And that's actually something that can be a very good question in the ward. Most places are not using it to change therapy.
Does MGMT promoter methylation prognostic also just the level that MGMT?
The promoter is the prognostic part.
Okay.
The level is not associated with prognosis because the assay isn't very good.
Okay.
And assays are different. Also, there can be And just like promoter methylation with any kind of tumor sample, there's going to be heterogeneity. And that's the tough part. Okay. So the theory is that, you have this MGT expression is reduced, you have a hypermethylated MGT tumor promoter, and then cytotoxic infections from the cancer. But with a lack of sort of good alternative treatment and sort of another pathway to treat some unmethylated patients, we're giving them a tumor. So it is very scientific. Now, there was a study looking at an integrin inhibitor called polynucleotide. So I think integrins are important because of the vasculature of the tumor. And unfortunately, that data isn't out yet to show whether that integrin inhibitor will be specific to treat some unmethylated patients. So I wish I could, we're about to end now. The last part is really talking about targeted therapies in tumors and sort of the bevacizumab controversy, okay, and the use of bevacizumab. I'm supposed to end right now. Can I have 2 more minutes? Do you think you have 2 more minutes? I probably can talk about it. Okay. So this is targeted therapy for brain tumors. So essentially they had all of these different gene targets that they wanted to use. They were very excited. But unfortunately, targeted therapy hasn't panned out to where we want it to be for brain tumors. We want it to be the melanoma story, right? We want to be the lung cancer story. We're still hanging out with pancreatic as far as I'm concerned. We want to be, we want to have a good story. We need to understand these targeted agents. So, glioblastoma was a very good target to use VEGF, which is actually an immune growth factor. The tumors are highly vascularized, it's staining VEGF very well, and it seems to be a very good target. Okay? The bevacizumab is an anti-VEGF antibody, okay? And it's thought to inhibit immunogenesis, to have an anti-glial effect on tumor cells, to normalize tumor vasculature, and to inhibit the stem cell niche for microvascular proliferation. Bevacizumab is given IV. We give it every 2 weeks. It can have a dose range anywhere from 5 to 15. If we give it on a Q3 week or a Q4 week schedule, they go up to 15 milligrams per kilogram. Toxicities, there's no toxicities of bevacizumab, okay? And also, it can have expressive procedures, okay, associated with being on the agent because of the surgical implications. But we actually were primarily used to the treatment of recurrent GBM, okay, and recurrent AAs. This was first used by Dr. Vandenberg here in Katy. And because progression-free survival of recurrent tumors at 6 months was 9 to 16%. So this was approached as a brain study, okay, and what this was is patients with a first relapse of glioblastoma received either bevacizumab or bevacizumab plus irinotecan, okay, and then were followed for survival. And what they did is they had very sort of similar survival patterns, but what I want to show you is overall, okay, remember that statistic of 9 to 16%. 6 months progression-free survival. The 6 months progression-free survival, when the patients received some type of bevacizumab regimen, was 42.6 to 50.3%. So this seems to be a very exciting time, okay, for the brain tumor community. And one of the things is, can we take this? This actually, because of this study and these results in this phase 2 study, this is FDA approved, okay, for the treatment, okay, of recurrent glioblastoma, okay, bevacizumab one. There's a lot of controversy of whether it's just changing the MRI, whether you're getting some kind of response, or whether you're just controlling the edema by how the drugs work. Okay? So one of the big questions was, what will happen in the newly diagnosed population? Okay? So they had 2 very large randomized studies. AVALIO, which is a European study done by Roche, and the RTOG 0825. And the primarily talk about the RTOG 0825, okay, because it's one that's causing most controversy. But it wanted to look at the first line use of bevacizumab with that same standard of care, that radiation and temozolomide, followed by temozolomide. And they randomized 637 patients, so 317 received combined radiation therapy with temozolomide and placebo, which is standard of care, and 320 received the standard chemoradiation therapy with bevacizumab every 2 weeks. Okay? And there were amazingly fun. We actually stratified them by MGMT, methylation promoter status. We also had a 9-gene signature that's used primarily out of MD Anderson. And as these progressions that were unblinded, and the patients could actually cross over to the other side. And these are what the curves like. And the top curves are from RCMP, and the bottom curves are from Apple-Leo. Okay? And what it shows is that this is actually progression-free. This is overall survival. Yes, this is overall survival.
Yeah.
Yeah, this is progression-free survival. Correct. New slide. Oh, yeah. And what they showed is that really there was no difference in overall survival for either group. And actually, in fact, the bevacizumab group in the RCOG study actually did a little worse in overall survival. So right now, where we're at from the bevacizumab session is it has some utility in the recurrent population, but for the newly diagnosed population, there doesn't seem to have a place right now. Now, there's a big controversy again with the cancer letter. So the big controversy is actually there was conflicting data in regards to neurocognition and quality of life in these two studies, because the Avoglia study showed that the vaccine actually improves quality of life and neurocognition, whereas the RGOG study showed that the vaccine actually caused it to decline. So because there's these two dichotomous results, especially with these things, the FDA is asking to go through all the data again. Okay? I actually have my neurocognitive data and quality of life data waiting to be published for that patients. Yeah, so I look like an evil movie from the movie Google Me. So we're going to have like a little foray into this also, and sort of help this out. Maybe we'll need the third time.
Tiebreaker.
The tiebreaker. So we're going to have a huge amount of data and over 1,000 cognitive tests for cancer patients. So these are the interesting research I have to share.
Well, and this is always the thing too about neurocognitive stuff. Like, there's a discrepancy between neurocognitive testing too and sometimes like actual objective clinical outcomes, like as far as how much it really means. The meaning of whether you can do the PEGs or
exactly.
What does that mean in real life?
You need to have a very durable measure that isn't you try to take the subjectivity out of it. So I have neurocognitive testing also in breast cancer patients, head and cancer patients, lung cancer patients, prostate cancer patients, with the same data I'm using on brain cancer patients. And what you can really see is there's this really big difference between my breast cancer patients and those other cancer patients. But how that links into survival, we still don't understand. We're doing that analysis now. I'm working primarily on these. Yes.
Is there data on beyond progression in the second line?
So there's data about using Bev beyond the final progression. So there's actually a study going on right now called bevacizumab beyond progression. So that's actually that's what you're talking about. So we're actually doing that study right now to continue bevacizumab beyond progression, stuff like that. There's been a retrospective analysis done by Dr. Reardon, which did show that keeping people on bevacizumab longer they had to have a better prognosis. But that was a retrospective analysis. The prospective analysis is happening now. So right now, the primary conclusion is that you can't support the use of Bev in vaccine patients. So pretty exciting. I'm going to leave the rest of this slide for you. I just kept this slide to talk about the patterns and what they look like. I think they're really important. Okay, we show the different patterns of the MRI. Okay. And then I talked about supportive care, which I think you guys know pretty much. And then this is a patient MRI, so I'm going to share this because he shared his slides so gratefully. And I was at the take-home point, we're doing better at treating some patients, we still have room to improve. Be a neuro-oncologist, don't be benign hematology.
You will find everyone in here agrees with you on that.
Definitely, Social Security commercial, our patients are wonderful. And this is one of our patients, he's a long-term survivor. He's actually had two insurances. He's off therapy now, he's doing great. And I love what insurance says because it happens how you feel on chemo. I love this. It goes on randomly, pain confused, bruised, confused, diffused, and my tumor has decreased. So I like that. So he's a great guy. So thanks to our patients, thanks to you guys for listening. Sorry I packed a lot of stuff in there. That was 111 slides, an hour, okay?